So we're going to cover really amyloid PET-CT today. Clearly, FDG PET has played a role in the diagnostic evaluation of the cognitively impaired patient for many years. It will probably still have a role, and we'll cover that a little bit, but we're going to focus on the role of really PET-CT in patients being entertained for the anti-amyloid therapy that was recently approved. As you guys know, there are many patients in the United States. 1 in 9 individuals have cognitive impairment. There's certainly many etiologies for cognitive impairment. And we're going to focus really on Alzheimer's patients because there's a disease-modifying therapy that was recently approved by the FDA, and Medicare has stated that they will pay for it. We will look specifically at that cohort of patients. This could be a tremendous amount of patients to, 16 million patients with cognitively impaired. So you'll have to screen more patients to really find the patients that have Alzheimer's disease that potentially could get the anti-amyloid therapy. When we position the two different technologies, we're looking at patients that have really a high pretest probability for having Alzheimer's, where you're entertaining the anti-amyloid therapy. Those patients will need either an amyloid PET CT or a CSF evaluation for amyloid to be qualified for the therapy, and we'll cover that in this presentation. As you are familiar with, FDG certainly has a really good diagnostic accuracy for looking at patients with cognitively impaired to find their etiology. We're not going to cover that too much unless there's some specific questions, but basically we're looking at cold spot imaging or dysfunctional neurons, and the pattern of dysfunction really dictates the underlying disease process. According to the package insert, it's not good enough to have a positive FDG PET-CT for Alzheimer's disease to get the therapy. You really have to have amyloid documented within the brain. As you can see from this graphic, in the patients that have Alzheimer's disease, amyloid beta 42 gets deposited in the brain and plateaus early within really the preclinical phase. So when we look at the patients in the MCI cohort, which would be your therapeutic population of patients, you already see that amyloid is typically diffuse and very high within the context of the gray matter. We'll look at some specific scans. You do see that the FDG lags the amyloid curve, and in that MCI cohort, there's a very difference between the FDG sensitivity and the amyloid, so that if you do have patients that have had normal FDG scans and you're considering that they still have amyloid, there is added sensitivity in that MCI cohort to add on a amyloid evaluation, either CSF and or amyloid PET-CT, and vice versa. If you have an MCI patient that has a negative amyloid evaluation, FDG may be additive, because if they don't have Alzheimer's, certainly FDG can tell us if they have Lewy body's disease or some other etiology for their cognitive impairment. So we're really going to focus on the right side of this graphic. We have had discussions on the left side of the graphic. FDG really is a diagnostic tool. And again, the pattern of FDG abnormalities dictate the underlying etiology, so that Lewy body's disease looks different than frontal temporal dementia, which looks different than Alzheimer's. If you have a high clinical suspicion for Alzheimer's disease and you're entertaining the therapeutic, you're going to need a biomarker to guide that therapy. There's basically two choices now, the CSF biomarkers and the imaging biomarkers. There are blood biomarkers that we'll discuss. Those are available in the U.S. market. They are not, they weren't done in the lecanemab clinical trial, so they're not good enough to, when you get a positive blood biomarker, to give the therapeutic. It either has to be the CSF biomarker or the imaging biomarker. So the blood test, just to describe it, again, some clinicians in the field are already doing this, and basically it gives you a amyloid probability score. It looks at both the amyloid beta 42 to 40 ratio in the blood, as well as the APOE4 allele genotype. And you can see the accuracy is actually pretty good. The sensitivity is about 92%. Specificity is a little bit lower, about 77%, but because it wasn't necessarily done in the clinical trial, it won't necessarily be good enough to put the patients on therapy. This is just an example from a particular patient, and you can see that it not only does the genotype for the APOE4 allele, but also for the amyloid beta 42 to 40 ratio in the blood. And then it gives you a score. 0 to 35 would be basically consistent with the absence of amyloid plaques on an amyloid PET CT, the intermediate, and then the high risk patients. So there are clinicians that are utilizing this, and basically in the curve I just showed you, or the flow diagram, they position the blood biomarker up front. The APOE4 allele, we'll talk a little bit about it, because patients that are homozygous for the APOE4 allele are at higher risk for having ARIA with the therapeutic. So this blood biomarker may play a number of different roles. Number one, risk stratifying the patients according to the ARIA that we may see, or the side effects, one of the side effects that you get with the therapeutic. So we'll talk now about the CSF biomarkers and the imaging biomarkers. Certainly the CSF biomarkers are available in the United States. It gives you both tau and amyloid beta. It's a little bit more accurate than just the imaging biomarker, but it is invasive. As you can see from the package insert for lecanemab, these are MCI, or mildly demented patients, so early stage disease populations. And you'll need the amyloid beta biomarker to be in the patient, and that's either imaging and or CSF evaluation. So the CSF biomarkers widely available, they're reimbursed, they're much less expensive than the imaging biomarkers, they're more accurate, and they can assess both tau and amyloid beta 42, but they are invasive, and certain populations of patients can't get a CSF study. You can see the accuracy from this review article from 2021, both looking at amyloid beta 42 as well as tau in the MCI cohort. Has a really high diagnostic accuracy by combining the two together. You can see the sensitivity is 92% and the specificity is 90%. So relatively good diagnostic accuracy. Over the blood biomarker, you can see about a 13% improvement in specificity and a little bit higher diagnostic sensitivity. Just to look at it from a patient's perspective, this is a patient with Alzheimer's disease, and you can see that total tau, which is a biomarker for neuron injury, is high in the CSF in patients that have ongoing Alzheimer's, and amyloid beta 2, because it's deposited within the context of the gray matter, you can see it's low in the CSF. So when you do a phosphorylated tau to an amyloid beta 42 ratio, you can see that it's high and above the standard range. So combining that, again, gives you a relatively high diagnostic accuracy and would be enough to give the therapeutic. Just to show you the tau, there are tau imaging biomarkers that are available on the PET CT. They are approved by the FDA. They are not commercially reimbursed. One of the thoughts of when to stop the therapy is when the tau becomes negative. These are used in clinical trials. We don't know whether they'll have a clinical role in the community setting or not. We're supposed to hear from CMS on the 15th of October what their position is on all the imaging biomarkers, both amyloid and tau. So we'll know a little bit more in a couple of weeks, but I just want to show you the tau image. This is a positive tau in a patient with Alzheimer's disease, and you see that there's increased tau accumulation within the parietal and temporal lobes. And if you contrast that to the FDG, which I'll show you in a second, it's actually the inverse of the FDG scan. So FDG is a biomarker for normal neurons, and if you have neuron death going on, they show up as cold spots on the FDG scan. But tau is a biomarker for active active neuron injury, and so they'll show up as increased accumulation of the tau radiopharmaceutical in areas that are undergoing neuron damage. So this is the tau image, and this is a FDG in Alzheimer's, just to show you that they're it's actually the inverse. Here you can see parietal lobe hypometabolism with FDG, and if you look at the tau, you can see increased tau accumulation. So we don't know how tau is going to play a role yet, but some of the thought is, since we don't have a good clinical biomarker to say, yes, the therapy is working in a particular patient, the question is, do we repeat tau on therapy to then say, okay, we can stop the therapy, the patient's benefited from that? Because as you guys know, patients clear amyloid with the therapeutic at different rates. And if you're still on therapy, but you've cleared all your amyloid, then all you're doing is subjecting the patient to the potential side effects of the therapeutic. So the imaging biomarkers, there are actually 3 of them available in the United States. You can see the specificity is relatively high, sensitivity is relatively high, certainly comparable to the CSF biomarkers. Because amyloid plateaus very early in our patient populations in the MCI and mild cognitive, mild demented patients, these are pretty straightforward from an imaging perspective to interpret. Typically, we're seeing a diffuse amyloid deposition in the brain in patients that have Alzheimer's, because you can see it plateaus really in the preclinical phase. So just to show you some examples, if you haven't seen these are amyloid images. So we inject, we wait a period of time, we take a picture. It's a lot faster than a whole body scan. Basically, we're taking one field of view rather than multiple fields of view when we do cancer imaging. So this is a negative amyloid scan. You can see regions of interest drawn. We do quantitative analysis on all of our brains. I actually serve as a consultant to Shields. I train the radiologist, and we do offsite brain quantification for all the FDGs as well as the amyloids. And here you don't really see any amyloid deposition within the gray matter. You do see it here in the white matter, and that's a normal biodistribution of the radiopharmaceutical. I will show you a number of abnormal cases so you can make that distinction. Here's a patient that has an abnormal scan. And you can see here that you don't really have good contrast resolution between gray and white matter. In fact, you can't delineate the two here. So you see diffuse amyloid deposition here in the gray matter. And again, the key from an interpretation perspective is you don't really see that distinction between gray and white matter. Here you see the regions of interest again. This is just the quantitative color. Basically, the computer system colors in areas that are abnormal. The more yellow the more significant it is for the particular patient. There is no real prognostic significance to having more amyloid deposition in the brain. As you saw from that in the first graphic I showed you, basically it plateaus early and it doesn't really correlate as the patient gets worse from a symptomatic perspective, which is different than the prognostic capability of FDG imaging. Just some other examples. This is a patient that was being considered for anti-amyloid therapy. He was on Coumadin, so he needed a non-invasive assessment of amyloid. And here again, you can see diffuse amyloid deposition within the gray matter. You do see some distinction between white and gray matter here, so it's certainly not as severe as the previous patient, but you do see, again, diffuse amyloid deposition in the brain here. And then quantitatively, you can see the yellow. So there's colors in areas that are abnormal. And again, we use this as a visual aid when we're visually interpreting these studies. This is another patient, 60-year-old. He cannot undergo a CSF biomarker. He had a lumbar fusion, so he had a CSF biomarker. And again, here you see very good gray-white matter distinction, or good contrast resolution between gray and white matter. And so this is a negative study. Again, certainly looks different than the previous patients. And a patient with MCI, again, seeking amyloid evaluation due to the new therapy. And you can see again here, diffuse amyloid deposition within the gray matter, again, consistent with an abnormal scan. So if you're as a clinician, if you start down the FDG algorithm, as there is synergy in adding an amyloid in patients that get a negative FDG, especially in that MCI cohort. The sensitivity is a little bit amyloid peaks first, and then FDG shows up as abnormalities. So if you're leading with FDG and it's normal, there might be added value of doing an amyloid evaluation in your patients, especially in that MCI cohort. And vice versa, if you're leading with the amyloid evaluation and it's negative and you're seeking a diagnosis of why the patient is cognitively impaired, we know it's probably not Alzheimer's in that case, and FDG can add added value in distinguishing other types of neurodegenerative disease that would not be amyloid related. Just a couple of comments about lecanemab and the response and ARIA. As you are well know, there's basically two side effects that patients get with lecanemab. One of them is an acute infusion reaction, just like any other drug that can be allergic to it. So there is a set of patients that do have acute findings with the infusion therapy. And then ARIA, or amyloid-related imaging abnormalities do show up, and we'll cover them. So there are protocols for patients on therapy getting a series of MRIs in follow-up. This drug does a relatively good job at clearing amyloid. This is just from the phase 2 study. You can see placebo versus lecanemab, and again, serial amyloid plaque imaging, and you can see that the SUV dropped, or at week 79, you can see that it was significantly less than it was at the beginning. From a symptomatic perspective, again, this is from the trial, you can see there's a deflection in the curve, those patients on placebo versus 10 milligrams per kilogram every 2 weeks. So that's the dosing recommendation from the package insert, bi-monthly dosing, and you can see the patients symptomatically are getting better, and there's a deflection in the cognitive decline of the particular patients. So ARIA is something that a lot of people are talking about. This is the largest chronic side effect of being on the therapy. These are from the phase 2 trial. This was patients with early AD or mild Alzheimer's disease, 18 months, and it looked at the biweekly optimal dosing strategy for the drug. ARIA occurs in basically two different forms, ARIA E, which is vasogenic edema, and then ARIA H, which is hemorrhage. Those patients that are APOE4 allele homozygotes are at higher clinical risk for having the ARIA H develop. The incident rate for lecanemab is actually relatively low compared to some of the other drugs that are either FDA approved and/or in clinical trials. The asymptomatic rate or general rate is about 10% of the population. Symptomatically, about 3% of the population develop ARIA E. And then ARIA H, again, is around the same, but can actually be more severe. It typically occurs early, so less than 3 months on therapy. Those are the patients that typically do get the side effects. And it's higher in APOE4 allele homozygous. So you'll probably want to do that initially in your patients to get their risk profile set up for how likely they are to develop the imaging side effects. This again just looks at the severity. Most of these patients again have mild and are asymptomatic, but certainly there are some patients, about 1.2% of the patients in the bi-weekly administration developed the severe ARIA H, and you can see ARIA E severe was about 1.2% of the population as well. Just to show you what it looks like. Again, macro hemorrhage with ARIA H, and then vasogenic edema with the area E. These typically do resolve off therapy. And again, though, there are specific MRI protocols that we'll talk about before the 5th, at the beginning, before the 5th, before the 7th, and before the 14th infusion. If you have a patient that develops a area E, say, and they're asymptomatic and it's mild, and you continue them on therapy, that will change your MRI protocol, and you may want to watch them more closely. Again, this is mild area E. So they're usually asymptomatic. The package insert requires MRIs prior to the start of therapy and then before the 5th, 7th, and 14th infusion. Patients on anticoagulation therapy that are homozygous for APOE4 allele are at the higher risk of brain bleeds. So that may be a consideration on whether you administer it or not administer it. Anticoagulation therapy in and of itself is not a contraindication, but in those patients that are homozygous for the APOE4 allele, that would be a relative or at least a discussion from a patient risk-benefit profiling. There's limited data on continued dosing following radiographic findings of ARIA. As you'll see in some of the recommendations that I'll review, it may be continued in patients that have mild ARIA and that are asymptomatic. And there's, again, recommendations on when you stop therapy or when you would hold therapy. So, again, if you start out with microhemorrhages, you're more likely to develop them. And then in the APOE4 allele homozygous, those are patients that have higher risk for developing ARIA. Area H increases with age and a history of cerebral vascular disease. Relative contraindications include greater than 4 microhemorrhages to start out with, or patients on antiplatelet or anticoagulant therapy, specifically if they're in that APOE4 allele homozygous cohort. So these are the classifications, again, from a radiographic severity perspective. And again, you can see mild, moderate, and severe, both the area E and area H. And then what you do with that information based on the imaging. Are they symptomatic or not? And should you suspend dosing or not suspend dosing? So you can see in both the area E graphic that if they're asymptomatic and they're mild on the MRI, you may continue dosing. You may change your MRI protocols to watch those patients more aggressively. And even if they're mildly symptomatic, you may continue dosing. If they're moderate, again, on the MRI, and they're either asymptomatic, mild, again, you're going to suspend dosing. And if they're severe, you would suspend dosing. These resolve over time. So you may reinstitute the therapy at some particular point in the future if, in fact, the MRI does resolve. And then the area H, you can see, again, the only cohort here where they say you may continue dosing would be the asymptomatic patients that have mild findings on the MRI. Everybody else is recommended to suspend the dosing. Just to show you just a graphic, again, at the baseline, we'll have a cognitive assessment. That's why they're coming in with cognitive impairment. You'll get your baseline MRI. You'll have some sort of an amyloid assessment to get them on therapy, either CSF or imaging biomarkers. You'll probably want to do an APOE4 allele. Are they homozygous or heterozygous, or they don't carry that gene at all? And then if they're on infusion therapy, this is stacking biweekly infusions. And then prior to infusion number 5, you would get an MRI. Prior to infusion number 7, you would get an MRI. And then prior to infusion 14, you would get an MRI. These MRIs, if they're normal, again, that would be the sequence recommended. If they're abnormal, say you develop on the first MRI, mild area E, then you may want to change your MRI protocol specific if you continue the therapeutic in that population of patients. And in those patients that have maybe had symptoms that have moderate area E, and you take them off therapy, you'd repeat your MRI. If it normalizes, if you institute therapy again, you may want to watch them a little bit more aggressively with MR. So we really focused on this graphic, again, CSF and imaging biomarkers. I will say that everything's not quite figured out yet from a Medicare perspective. As you know, the imaging amyloid biomarkers have been in the marketplace for a number of different years. They've actually come off a pass-through, so they're basically done in the community setting now. We don't know, and right now, as the rule states, you can get one amyloid for your lifetime. So that's not necessarily going to fit within the context of reinstitutions of therapy and all of those good things that patients may get now with the disease-modifying therapy. So there was an open period for Medicare to take comments from the public. That stopped sometime around the 1st of September. They're thinking about it now. We're supposed to hear something on about the 15th of October, which is in 2 weeks, on what the coverage policies are for the imaging amyloid biomarker, as well as probably tau, and how that's going to develop into the algorithms from a therapeutic perspective. So stay tuned for that. Certainly, we are seeing some activity in the marketplace with amyloid being done in some patients on trials right now. That is reimbursed by CMS, but probably we'll get some clarification from CMS around the 15th of October. Any questions at all?
So we have a question on text here, and I'm just reading it, but I got to pop up here. So SJB, yeah, if you'd reach out to Haley Camerata, who is on here, maybe throw us an email address that we can reach out to you. We can talk through the difficulty that you may be having. It may be primarily, if it's insurance related, we can tell you what we know. So happy to work with you on that. Most of you are on mute, and we're going to let you voluntarily jump off to ask if there's any questions at this time. Excellent. Dr. Bridwell, fantastic presentation this morning. Thank you very much. Everybody that has joined today, know that your sales representative for Shields is available in the field. So if a question comes up later, please reach out to that person. Dr. Bridwell and Shields work very closely together. Haley and myself are very involved in the operational components for the PET-CT, and we'd be happy to guide you medically. We would connect you with Dr. Bridwell. But I thank you for your time this morning. Any final questions before we leave? Great. I wish you all a great day. In New England, it looks like it's going to be beautiful today, so enjoy. Thanks for joining.